Welcome to video 12 of the Safe Recovery Training Program, Information Provision and Reviewing Threat Appraisal. I'm Terry Haines. The objective of this video is to understand the purpose of using video as a media to share falls prevention information with a patient, and to understand how to review the impact of showing the video information on patient understanding of the problem of falls and how they may be likely to fall in future. You'll recall that the Safe Recovery program is structured in two phases, an information gathering phase and then an information provision and joint problem solving phase. In this video we have entered the information provision and joint problem solving phase. First, we discuss showing the video. The video and the workbook are designed to inform. They're designed to inform about general threat appraisal, to raise the issue that falls do happen in hospitals with the patient, and specific threat appraisal, so that the patient starts to get a realistic understanding that they are likely, it is possible that they will fall over themselves while in hospital. It's designed to inform the patient of some simple prevention strategies, such as the 3 simple steps to stopping falls. It's there to encourage goal setting by the patient and also to inform the patient that the goal will be checked or reviewed, and this is to help promote accountability of the patient to the goals that they have set. The advantages of showing the information via a video or by using the workbook rather than just telling the patient verbally there are 3 main advantages. The first is that it saves you time. The second is that it avoids your discussions taking on a didactic I'm telling you approach. The third is that it allows some basic information to be conveyed without the patient thinking that you think they're not intelligent. And that helps to build rapport. So normally, just prior to showing the video to the patient, I will tell them that I'm about to show you a video. It goes for about 16 minutes altogether. So I hope you're comfortable to watch it. Now, it's a fairly simple video. I think you'll find the messages quite straightforward to understand on it. We've designed it to be able to show to every patient in the hospital regardless of where they're at. So it's at a fairly basic level. So someone like you should be able to understand it pretty easily. Now, you can couch the showing the video in those sort of terms to every patient regardless of how easily they're going to take that information on board or not. Again, it's about building rapport so that they're not sitting there looking at some very simple messages thinking, man, this guy thinks I'm an idiot. The video design features are that there is slower than usual speed of speech. This allows time for the patients to absorb information. The auditory information processing speed of older adults may not be as high or as quick as younger adults, so we've slowed the speech speed down. There is repetition of key points. There is repetition of key points. That's my little joke. And we provide an older adult main character to promote peer modeling. The video design features, its overall length in the research was about 17 minutes, and we kept it as short as possible to avoid information overload. We wanted to minimize the amount of information we wanted older adults to absorb. Therefore, we focused on issues and strategies that we thought would be the most important for preventing falls while in hospital. Although there is a plethora of potential falls prevention strategies, we did not want to load these onto the patient. We wanted to keep it simple and specific. The version available on the web on YouTube is about 16 minutes long. We removed the instructions for how to use a portable video player as a part of the video, that is how we showed patients the video in the research. However, as the video is available on YouTube, you'll be able to download it and just show it to patients on iPads or various other media that you might have available to you. Other video design features. The data presented in the video is on the more severe end of the spectrum intentionally. So we have statements such as 1 in 4 fall, and up to 1 in 3 falls may result in an injury such as a bruise, skin tear, or broken bone. Now, obviously, 1 in 3 falls don't result in a broken bone. However, we've grouped this in with the other injuries because we need to promote threat appraisal. The problem that we face in hospital is the perception of risk of falls and of injury due to falls is too low. The pendulum has swung too far in the falls are not a problem direction. There are some out there who would criticize my approach here and say that no, we don't want people to become fearful of falling. But again, I am of the opinion that we need to give patients a realistic understanding of the clear and present danger that falls present to them during their hospitalization, and that it is something that needs to provoke action on the patient's behalf while they're staying with us. A further element was that the graph of falls and time of day emphasizes 2 time points, in the morning and in the afternoon and early evening, as key times when patients fall over. Now, the difference between these time periods, fall rates, and those at lunchtime or during the middle of the night are not as dramatic as what is shown on the graph. Again, I've tried to emphasize these points to provoke action, to draw patients' attention to these particular points. Now, where possible, please show the video to patients. Previous research that our team has undertaken has demonstrated that this has a greater effect on knowledge uptake compared to looking at the workbook alone, and it also enhances patient motivation to participate in prevention strategies to a greater extent. And details of that research can be found in this publication in the Journal of the American Geriatric Society. When showing the video, I'll set the person up, tell them it goes for about 15 minutes, and then let them watch. Just make sure that the patient doesn't need to go to the toilet or have other matters attended to before commencing. Because if someone is desperately thinking about going to the toilet or in severe pain, they're not going to be focusing on the materials being demonstrated in the video. Following on from showing the video or the workbook, we then come to the point of reviewing threat appraisal. Now, this is something I didn't get you to do in self-learning activity number 2, but it's something that you need to do when providing the program. We need to ask the patients whether watching the video, really up to the end of chapter 6, changed the patient's perception of falls in general, so their general threat appraisal. Do falls happen in hospitals? Where, when, and why falls occur? Their own personal risk of falling, and where, when, and why they might fall if they were to. Now, some patients understand very readily the message in the video. We're trying to tell them that falls happen at the 2 peak periods during the day, that they're more likely to happen at the bedside than any other area, and usually during an innocuous activity where the patient does not have a staff member assisting them. This is the new sort of fall that we expect patients to say, right, if hypothetically I was to have a fall, I think now, after watching the video, that I'd be falling by the bedside, probably in the morning, trying to get my shoes on without the nurse being there with me. Now, other patients are much slower to take this point up and understand this message and how it potentially applies to them as an individual. Now, some patients do not want to consider the possibility that they are at risk of falling at all, and it may be difficult for them to engage in this discussion. And there are a number of patients out there who will be like this. But basically what we want to do is move people along the threat appraisal hierarchy. We want them to get a realistic understanding that people do fall over while in hospital, that people like them are likely to fall over while in hospital, and that they are too at risk of falling over while at hospital, and in a similar vein that they are at risk of hurting themselves if they were to fall over while in hospital. So by finding out where people sit on the threat appraisal spectrum before watching the video, and then finding out again after watching the video where they sit on this threat appraisal spectrum, you'll be able to understand how much information they've taken on board as a result of watching the video. Now, it's not unusual, again, that some older adults feel like they are indestructible and that falls certainly don't apply to them. Everyone feels that they are different and special, and that even though there are other people like them who might be at risk of falling over, it won't happen to them. If the person does not accept that they're at risk of falls, the thought of loss of independence and impending mortality may be creating a cognitive dissonance in their mind. It's a slippery slope. If I accept that I'm at risk of falling over, then I have to accept that I'm getting older. I have to accept that I'm losing my independence. I have to accept that eventually I'm going to die. And those thought processes may be a very difficult, connected series of thoughts for an older adult to have. And for some, the best way that they can deal with that is to shut that thought down and to just deny that at the very start that risk of falls applies to them at all. Now, you can attempt to contrast to other people. You can say, oh, Mrs. Jones in the bed next to you, she walks with a walking frame as well, and she fell over. Of course, not wanting to violate patient privacy, of course. But attempts to do this may backfire, again, because people believe they're individuals, that they're different and that they're special. It may be best to give patients time to think about it. Quite often I've found that after the first time showing the video, people can be a little bit defensive about discussing their risk of falls, and at that point I might leave them and come back the following day and get them to re-engage in that discussion after they've had a little bit of time to ponder and to consider what was said in the video. And sometimes that's all patients need, a bit of time. So there's no need to bash people into submission about thinking that they are at risk of falls. If someone does not think they're at risk of falls even after watching the video, you can leave them with that. That's okay. Give them some time to think about it, and you can come back to them the following day or in a couple of days' time to re-engage on the issue. If a person is steadfastly not going to accept that they're at risk of falls, then the other approach that you can use to try and help them engage in falls prevention behaviours is the do it for me approach, which may be best. This, of course, relies on having a strong rapport, a strong relationship with the patient that you have developed. So you don't necessarily want to push your risk of falls line too hard for fear of damaging that relationship. Always bear in mind framework 2. I've spoken for a bit of time about threat appraisal because I believe it is central for patients to have an appreciation of the risk of falls that they face, even if they're not willing to say it out loud or to say it to somebody else like yourself. If patients have an appreciation that they may be at risk of falls and they may be at risk of harm if they were to fall, then they will see potential benefit from undertaking falls prevention behaviours.